The OASIS question about dyspnea is interesting and unique in that there's only a limited amount of guidance on it. There are other OASIS questions where the guidance tells us what to consider, what not to consider, and then further interprets the question and the item choices, but not so much on dyspnea. There's a very special piece of guidance, however, that I want to talk about. You may have heard it before. Good, because maybe I'll expand your vision on how to apply it. If it's a new concept to you, well, that's also good, because now you'll be able to apply it in your next OASIS assessment. And in this presentation, I'm going to briefly review some of the basic information about dyspnea and then put the spotlight on this rather empowering guidance. We're all pretty familiar with what typical dyspnea looks like: increased respiratory rate and effort, accessory muscle use, the tripod or propping position that's often seen in those with significant pulmonary disease. But it can also sound like someone grunting and breath holding due to pain or maybe morbid obesity. Dyspnea could also sound like shortened sentences in someone with significant truncal weakness, for example, someone with ALS or a spinal cord injury. It might sound like coughing in someone with fluid overload from heart failure. Let's review some of the disease processes and illnesses that can contribute to dyspnea. Pulmonary and cardiac diseases, acute or chronic, even acute on chronic. Pulmonary embolism from a variety of sources: DVT, AFib, Leiden 5 are just a few. Anemia and blood loss. We got post-op blood loss. We have blood disorders or blood cancers. Smoking or other inhaled chemical exposures. We've got so many patients who smoked cigarettes for years and years, and some of them still do. And then we have industrial or occupational chemical exposures. You think sometimes about our firefighters. And then morbid obesity, well, whether we're talking about the increased body habitus or the weight of the limbs, all can contribute to dyspnea. Let's look at some other factors that contribute to dyspnea. But unlike the disease processes and illnesses we just looked at, these factors are where we can and do intervene. Things like the conditions that impact energy consumption, whether that's severely impaired cardiopulmonary status, one-sided limb usage, restriction or weakness, weight-bearing restrictions, anxiety and fear, poorly controlled pain. Those things can contribute to dyspnea. Poor medication compliance, if our patients aren't taking their meds correctly or accurately, that's definitely going to impact. And ineffective utilization of their inhaled meds. What if they're not effectively using their inhaler and they're only getting a partial dose? Then they're not getting the full impact that will affect their dyspnea. Poor pulmonary hygiene. Some of our patients don't have good knowledge about it. Some have just poor compliance with the education that has already been provided. These are all the places and the problems where we build our care plans, goals, and interventions, teaching our patients how to manage their short and long-term medical issues. So let's look at the question. When is the patient dyspneic or noticeably short of breath? When? That means we're looking for an activity where dyspnea is observed. So that means when we're assessing for dyspnea, we need to get the patient up to move. Having the patient perform the OASIS walk through their home gives us a great opportunity to watch them move and transfer, and that's from a variety of surfaces. And having them remove their upper body clothing to allow for vital signs assessment, and socks and shoes for foot inspection, pants up and down for skin inspection on the buttocks, that gives us a chance to look at some dressing type activities too. We're looking for dyspnea during the time of the visit, but are also told to consider dyspnea that occurred in the past 24 hours when it's reported by the patient or the caregiver. So what are you supposed to do if the patient refuses to get up and move around for you? Well, you've probably experienced that patient who says, I just got into my wheelchair and I'm not getting back up. Or I just got into bed to rest. I'm not going to get back up right now. What do you do? How do you score dyspnea? Well, here's that pearl of guidance I mentioned at the beginning. We are told to use our clinical judgment. And now it's kind of earth-shattering, isn't it? And by using our clinical judgment, we are going to consider the things that we have been able to observe the patient doing in their mobility and their activities. We're going to consider any report of dyspnea, not their denial of it, only the report of dyspnea. We're going to consider their current medical history and their current medical issues, the things that just brought the patient to our services, like a recent stroke or surgery or perhaps an acute respiratory illness like pneumonia or COVID or even a COPD exacerbation. That's their current. but we're going to layer on top of that anything that's a pertinent past medical history. Perhaps an old CVA with long-standing weakness, chronic COPD, morbid obesity, things like that. And then, based on our observation, the current and past medical history, then we're going to consider how we think fatigue may have impacted their activities and their dyspnea in the past 24 hours. And always, we're going to be collaborating with other disciplines that are able to observe the patient's mobility and the presence of dyspnea during that collaboration time period. What if your patient uses oxygen? Do you assess them with it on or with it off? Well, guidance tells us that depends on how your patient actually wears their oxygen. Not how it's ordered to be worn, but how they wear it. So if your patient wears their oxygen continuously, have them wear it. If they wear their oxygen intermittently, assess them without their oxygen. So let's go back to the question. Remember, we're looking for a when. For this question, it is most effective to determine the score by starting at the bottom and determining if the patient fits that criteria. When you start at the bottom and move up, you are more likely to score accurately, as you won't miss if dyspnea occurred at a lower level than if you move from the top down. So let's start at the bottom and think about how you'd apply clinical judgment for the patient. At rest, you might see a patient with pillows used to prop themselves up at night or during the day. Maybe they sleep in a recliner. You might see upper extremity propping and accessory muscle use. But you might also see someone who has severe pain at rest, who's grunting and breath holding, or someone who's extremely nervous about the visit and perhaps is anticipating the pain that the care you're going to provide is going to cause. 3, minimal exertion. Guidance lists eating and talking, but then says other ADLs and tells us to use clinical judgment as to what type of activities require only a minimum of effort and produce dyspnea for your patient. Activities that are similar in effort to talking and eating could be upper body washing, grooming activities, rolling in bed. But again, don't forget about the impact of anxiety and pain. 2, moderate exertion. For example, that tells us to use our clinical judgment. We get to determine what activities, based on your patient and your clinical judgment, require a moderate level of exertion and create dyspnea for your patient. Things that they give examples of: dressing, using the commode, bedpan, and if you think about the movements that are required to do that, it might be sit to stand. Could be sit to stand from their toilet, sit to stand from the couch. But it's also walking distances less than 20 feet, and you could use your clinical judgment to include self-propelling a wheelchair for approximately 20 feet. We use ADLs to identify the when of when is the patient dyspneic or short of breath. But on the flip of that, the presence of dyspnea during an ADL doesn't automatically impact how you would score the ADL, unless the dyspnea creates a safety issue, like perhaps an oxygen desaturation below safe levels of 88%, hurrying, rushing, that impulsivity that may go along with trying to get it done quickly because they're getting winded. A patient can use various strategies we teach them and take extra time and use the pacing and some of the adaptive equipment. And if they do those things and perform their ADL safely, then the presence of dyspnea would not impact their ability to perform that ADL. I grouped the 0 and the 1 together under what I call higher level mobility. When you look at 1, walking more than 20 feet or climbing stairs, that's a pretty significant difference in level of exertion between those two things. But I want you to remember that under the GG items, we've got 50 feet and 150 feet mobility distances to complete, and those would actually fall under the umbrella of more than 20 feet. Once your patient's gone beyond the GG 150 feet distance and you've not seen or heard dyspnea anywhere else in their functional mobility assessment, then you could choose 0, not short of breath. And for your wheelchair level patient who doesn't ambulate, you would use your clinical judgment. A wheelchair level patient who has significant weakness and doesn't propel their wheelchair either at all or for only a short distance will likely demonstrate dyspnea with other activities, perhaps transfers or dressing, and they'd be scored accordingly, versus the wheelchair level patient who is strong and perhaps propels themselves down long corridors with no dyspnea observed, no dyspnea reported, nothing seen in other activities. They could be scored as a 1 or even a 0, again depending on the distances covered and if the dyspnea was observed, even though they don't ambulate. And that's because guidance says apply clinical judgment to the patient, the level of exertion, and how it applies to the activities listed. And just don't forget the impact of pain and anxiety. It could impact the dyspnea you observe at any point on the scoring spectrum of responses. Let's take a look again at the dyspnea factors I listed earlier that were part of building the care plans and the goals and our interventions. This is where the rubber meets the road. We teach our pacing and energy conservation strategies. We work on muscle strengthening by appropriately dosing our exercises for strength. We put adaptive equipment in place and teach our patients how to effectively use it. If anxiety, fear, or pain are part of the problems, we're helping to address those things. We're teaching our patients about medication compliance, the purpose of their medications, why they're important, how they're going to impact them. Sometimes knowing will improve their compliance. We're checking, we're assessing, we're teaching. Are they using their inhalers correctly, effectively? Are they getting the full dose of the medication? And hey, if they've got a bronchodilator, we should be facilitating the patient to use that prior to the exercises and activities that we're asking them to do with us. We're teaching pulmonary hygiene techniques. We're helping them to effectively use an incentive spirometer, use huffing and coughing. If they have an acapella or aerobica, we're double checking to make sure that they are effectively using it. And then sometimes we're even patterning that every session to get that muscle memory built in. And when we've done all of these treatments, many times we're going to see our patients improve in their dyspnea, even for the very impaired and compromised folks. At the start of care, we know that we're supposed to score the patients prior to any intervention or education being provided, and that actually applies to dyspnea too. Any cues at the start of care that we need to provide would be considered an intervention. During your treatment sessions, you've been patterning and practicing the skills and the techniques and the strategies and doing all the education to help the patient manage their dyspnea. So at discharge, let's ask our patients to demonstrate the teaching that we've been providing. Kind of like the big recital, have them show off for you. Hey, I want to see your very best today. Show me how you can use all those skills that we've been practicing. And then you can list them off to the patient to remind them of what they've been given and what they have available to use. If pain has been a contributing dyspnea factor, review pain management. Have them implement it. Maybe when you call to schedule the appointment, you say, hey, don't forget to take your pain medication so that you're ready for your activities today. Have them use their inhaler prior to their exercise and activities. Have them be ready. Have them perform pulmonary hygiene activities to prepare them for optimal performance. Remind them they've got pacing and energy conservation strategies to use to keep their breathing better under control. Say, show me how you can implement them. Ask your patient to use the most appropriate assistive device that you have been working with, even if they don't prefer it, even if they don't really want to use it and haven't been using it. Like, they want to use their cane or they don't want to use anything, but they are better supported in their dyspnea using their rolling walker. Have them use the adaptive equipment for you that has been the most supportive of limiting their dyspnea and supporting them. If they use oxygen but have been doing so sporadically, intermittently, for whatever reason, have them demonstrate their activity with it on. Review how to keep the cord out from under their feet, or help them use their portable tank, maybe their little intermittent flow tank. And then also have them show off their pursed lip breathing pattern if that's something that you've been teaching them. And when we have our patients demonstrate all that we've taught them, we're likely to see an improvement. And guidance says we let them apply all of the things that we've been teaching, and then we look for and assess any dyspnea that is still present and score according to that. We're likely to see some improvement. So if you still got questions about dyspnea or questions about OASIS in general, we've got answers. Feel free to reach out anytime. Jack, Allison, Lisa, and Rachel, their QA team, they love your OASIS questions and they love to share their knowledge. You can also reach out to your manager or your leads, and you know you always have me, the resident OASIS geek, for any OASIS questions. Feel free to reach out anytime.